what would you say is your biggest concern around the NHI?
So my concern is that people will do everything they can to sabotage it.
The GNU, how is that going to impact NHI?
The majority are opposed to the NHI. They say in its current form. We support the NHI, but not in its current form. Before 1 cent is spent on healthcare, 21 billion has already been spent. Oh, and then, by the way, the private sector is not without their fraud and corruption. 28 billion rand is defrauded from the medical schemes and the providers per year.
Welcome back to Palatable Politics, a show where we take the complexity out of politics and make it palatable for you. With me, your host, TJ Maslela. Welcome to the show. In today's session, we're going to be going into the NHI, having a deep dive into the pros, cons, and what we can expect. Here to make it palatable for us is Professor Nicholas Crisp, who is also the DDG in health, responsible for NHI. He has been a doctor in private, has worked in public, and is running the project. Welcome to the show.
Thanks, it's better. Pleased to be here.
NHI, what is it?
So essentially, national health insurance is a complete reform of the financing system, how we pay for healthcare in the country. So we all know that we have a parallel system at the moment where private healthcare is funded largely through pre-financing voluntarily to medical schemes, plus other gap cover, insurance products, and out-of-pocket payments. And the majority of people who use that payment system are buying healthcare or having it bought for them from private providers. On the other side is the public health system, where the tax monies that we pay to the government are paid to the provincial governments and some of it to the national government. And those provincial governments then provide healthcare to the remaining portion of the population so that the funding stream is purely tax money to government departments.
So in terms of the financing model of it, how would it work?
So what other countries have done and where we are headed is to comply with our agreement in the United Nations to strive for universal health coverage. We hear lots of strange words like universal healthcare coverage, universal access healthcare. None of the above. It's universal health coverage. It is an agreement signed in the United Nations by heads of state, reaffirmed in November last year, including by our own head of state. And it is managed by the World Health Organization as the member organization of the UN responsible for health. And essentially, what universal health coverage says is that every person must have access to the healthcare that they need, when they need it, where they need it, and it must be of a sufficient quality. And the key is without incurring financial hardship. So the day that I'm sick because I've got an appendicitis, I need healthcare at that point. I need it now, not deferred by 3 months or 6 months. I need it near to my home because it's going to get worse. I can't go to another province somewhere else. And I need to know that it's paid for now because I can't defer it and I can't wait and I can't go around to all the relatives while I'm in agony and raise the money to pay for it. I also can't expect to part pay for it and then spend the next 6 months or 2 years selling off my assets to pay for it. So that's what we are striving for. So the question is, how do we get that money to be equitably allocated so that each person can access healthcare when they need it? And the answer is that you pool it. So most countries around the world will pool it depending on the structure of their country. We'll pool it into one or more pools. But generally, we strive for a single large pool where everybody gets a set of benefits that the government can afford with the taxes that we pay. And that's the single funder model. As I say, there are multiple models and there are countries who have 2 or 3 different funds. But our problem is that we have 9 different public sector departments, each with which is a pooled fund, plus the national department that gives top-up money to them in the public sector, and 71 medical schemes, which have 311 options between them. So there are 311 pools administered or broadly categorized under 71 schemes, with a number of administrators who administer this money for them. It's extremely complicated, and it means that none of us has equitable access to the funds that somebody else has when we need healthcare. We want to simplify that dramatically over the next few years.
Some of the discourse publicly has been that currently public healthcare, in terms of policy or law, is free or should be. I should be able to go to hospital and get that free care. But that hasn't been run well. Therefore, people have resorted to private, and that's why private has the business that it does.
Yeah.
But now there are fears that NHI is going to mess that up. But if we just to go into the status.
Yeah.
You were a doctor before 94, you were a doctor in 94, and now.
Yeah.
If you were to just draw three.
Okay, 3 periods. Okay,
Yeah.
so I qualified in 1983. So from 84 to 89, I was in clinical practice in the old mission hospitals in what were called homelands. Young people like you will only have heard of them and not experienced them. But in the apartheid era, there were a lot of different administrations. There were 14 departments. There were 4 independent states and a whole range of what were called homelands or self-governing territories. So I worked in Gazankulu, in the Zanin area, and in a place called, at first at Letaba and then later at Mogoboya. So the environment in those days was that we didn't have a lot of private providers. We had a few. We did not have a lot of private funding. There was recently formed a couple of medical schemes, and it was the early days of medical schemes and pre-financed healthcare. So essentially, we got our healthcare, all of us, in the public sector. My children were born in the public sector. I got my own healthcare in the public sector. When I was a student, I was cared for in the public sector as well. I went to the dentist in the public sector. Everything was in the public sector in those days. There were private providers, there were GPs, and there were some specialists. Nearly all of them had sessions in the public hospitals working with us to relieve our pressures in our public hospital. And that's how it was sort of passed up to 1989, 90, up to 1993. During that period, medical schemes became more prevalent, more were registered, the Medical Schemes Act had come into effect, and private providers started to be registered. In terms of the Health Act that was applicable at that time, which was a 1997 Health Act, the minister was empowered to give licenses for private hospitals. There wasn't a requirement for licensing for private GP practices and others, and the pharmacies have always been registered in terms of the Pharmacy Act. So there was a transition where a lot of private providers, particularly private hospitals, were established. And frankly, there was a lot of racism involved in preparation for the 1994 elections, because white people knew that the hospitals that were previously reserved for white people would now become accessible to everybody. And one of the ways to preserve what they perceived to be quality would be to ring fence those hospitals in the private sector. And there were open discussions about it at that time. So that took us up to about 1994. In the period leading up to 1994 and published in 1995 was the first in-government new white paper on the transformation of the health services. That was before a paper on NHI. And if you go back to that 1995 document, the intention was we all deserve healthcare, we must all have access to all the resources, and we must get the healthcare. So it's pretty much what we are talking about in universal health coverage. And the question was how to pay for it. And for those who don't remember that period, we didn't have the constitution we've got now. In 1994 and 1995, we were still functioning, and part of 1996, we were still functioning on an interim constitution, which had a role to get rid of the old administrations, including the old health systems and so on. And a lot of laws were repealed, and a lot of transitional arrangements were made during that period. It was only from 96 we got the constitution we've got now. So all the old delivery systems were pretty much in place in that period. From 1996, the public sector, 1997 budget, the public sector budget was changed to what we call provincial equitable shares, and the money was not allocated through a central public fund. It went to the provinces as a lump sum, and they allocated money for health and education and their other functions. Shortly after that, the Treasury introduced conditional grants to try and deal with the differences that had resulted from the inherited resources. And in health, we got a lot because Limpopo and Mpumalanga, even today, don't have big tertiary hospitals. They certainly don't have central hospitals with universities. We're busy building one in Polokwane at the moment. So there was supposed to be an equalizer to allow for additional investment in those parts of the country that had suffered under the way in which monies were allocated. During that time, the private sector got bigger. The public sector was trying to cover all of these backlogs and reorganize itself and settle down into new, first of all, provinces. And then, of course, the districts were introduced because of the new 3 spheres of local government and so on. And it's been more recently that the district system has been implemented. And during that period, the private sector grew tremendously. And people with money, as we know, not a lot of people have employment in the country, so people with money have been insured. And the public sector put into place a range of public sector specific, what we call closed medical schemes. And they invested in those schemes to enable public servants to have healthcare cover. So that's the evolution of what we have seen. So I've been personally through this entire range of healthcare and seen the public sector being eroded by the fact that there's a lot of money in the private sector. People are prepared to pay a lot of money. So it makes it attractive for the resources to shift into that space. And as the public sector has become more difficult to work in, people then there's a push factor that pushes them out. So they're being pushed out and pulled into the private sector. And we have to arrest it somewhere because both sectors are imploding now.
The push was, the pull rather from the private side was largely financial, right?
Yeah, money.
And I mean, essentially, this would mean that doctors in private would earn less. And I mean, I guess
public would earn less.
Yes, in public would earn less. And that is why we have the threat of doctors saying they'll leave, they'll go to Australia.
Yeah. So remember, public sector salaries are negotiated centrally, nationally, in the public sector bargaining chamber. And there's a framework, so it's not negotiable. I think I'm good and I think I'm better than you. There's some performance measure that goes on, but essentially you are in a fixed framework. Whereas in the private sector, the more you do and the better reputation you have, and the more the better location you have or whatever, you can earn more. There are also perverse incentives in the private sector to overservice patients. There's fee-for-service, which you can add codes. There are ways in which patients manipulate the providers in the private sector, and so on. So there are challenges with the regulation and the regulatory space. And I know we are criticized as government that it's our fault we didn't regulate. That may well be, but we sit with a situation that we must deal with it now. And so now that government wants to regulate and put a system in place, you can't come back and say government shouldn't be regulating when you've just told us we should be regulating. There are ways to regulate, and whether you need the entire NHI reform is a matter that people will debate. We believe that you can't fiddle with the edges. You need to fundamentally reform, and we need to go the way that the rest of the world is going, and that's why we're reforming now. It's not to say that you shouldn't have your independence, you shouldn't be able to work privately, you shouldn't be able to establish your own environment, set up the way you look after the patients. But what we are interested in from government is the patient, the user of the health system. We would like to see that there's more care and more effort in the primary healthcare space so that people do not get sick. We don't like the hospital model where you wait for someone to have a stroke rather than prevent their hypertension. We don't want a situation where people come with some diabetic problem or advanced cancer because they've had to save up for money to get themselves to have healthcare, whether it's in the public or the private. So the investment has got to be in the primary healthcare framework, and we've got to make sure that patients don't bypass that system and use the expensive resources in order to get care. And we need a new framework to be able to do that. And that's what the NHI Act is designed to do.
I know one of the issues that they're trying to address, or rather put more in focus, is the use of GPs.
Yeah.
Can you give us a bit of context around why that is?
So people around the world will talk about gatekeeping. So the theory, and there's some evidence, is that if you gatekeep, if you make sure that you see, let's wind back one step. When you start in medical school, one of the first things they teach you is common things occur commonly. Don't look for the rare things first, because most of us will get those common things frequently and repeatedly, and we're all going to get them. And those are the bulk of healthcare is about the common things that occur commonly. And so they are sicknesses. They are things that can make us really ill, and they can deteriorate and get worse. But if you intervene in the periphery of the health system, closer to the households, closer to where the individual interacts with their community, you can prevent them from escalating and becoming a problem. And the structure of our system, in the public sector, it's always been nurse-led clinics, and they've done a darn good job for decades. But a nurse doesn't have all the training that a doctor has. So more recently, the attempt has been to get more and more medical officers, which are GPs, we just call them medical officers in the public sector, to get more and more medical officers to work with teams of nurses to enhance their training, to see the patients that have got problems that the nurse might not feel confident to deal with, and so forth. But a lot of our competent, experienced general practitioners, medical officers, work in private. And they don't work with teams of nurses. And the system that we have at the moment with the medical schemes has a perverse incentive to bypass the GP and to take your common thing that occurs commonly to a specialist. So what we would like to see is, over a period of time, is to put the emphasis back on the GP. Make sure that the generalist doctor is not bypassed to go and get more expensive healthcare to pay for from a specialist who we want to see the patients with complex specialist problems. So it's not like we don't want them. We don't want them to be spending a lot of their time on patients who don't need to see them. And we would like to see the GPs playing more of a role in supporting teams of nurses and community health workers and other workers in the primary healthcare space to provide that what we call clinical governance, because we spend a lot more time investing in the training of a doctor than we do for clinical care than we do in the other health professions. So if we can encourage people to work in multidisciplinary teams, change the way we regulate so that it makes it easier for them to do that, and pay them together as multidisciplinary teams, their challenge becomes to look after a community of people and not to look after a disease or a condition.
From what I'm gathering now, that at large, it's basically also fundamentally upraising the basic standard of quality healthcare.
Yeah.
There are the concerns about, how different provinces, like you're saying, have performed differently. How would NHI ensure that there's a standard quality across the board?
Okay, so let's first of all start by, when we use the word quality, it could be jungle oats, it could be cool drinks, it could be beer, it could be anything. So we use the word quality quite loosely sometimes. So the public would perceive the quality that the public is trained to see. Clean floors, TV in my ward, and toys for my children at the GP's rooms are quality to me. For the trained health practitioner, the quality is about the outcome. What percentage of your patients got an infection? How many of your patients actually got better? How many did you make worse by giving the wrong thing or not doing a diagnosis or missing something early? So there are quality of outcomes, and there are qualities of the inputs we put into the system. So we need to measure all of that. We need to watch all of that, because it all matters. Some more to the patient. The patient can't decide whether you got a better healthcare or worse healthcare than from another practitioner. They haven't got a way to measure that. They don't know what's expected. So we need to improve, all of us as practitioners, all need to improve and be improving our quality all the time. Get it right the first time, get it right at a cheaper price, get it right where the patient can get home as quickly as possible, get it right in a space that is clean and conducive to care. And we fail often all over the health system, public and private, often for different reasons. So what the National Health Insurance Act says is that in order for the fund to pay you with taxpayers' money, remember the government has no money. It's the taxpayers' money. The government's merely the custodian. You need to get this in our heads. This is not the government's money. This is your and my tax money. So how do we, as the agent of the taxpayer, ensure that when we pay somebody to provide you with healthcare, the healthcare that you need when you need, where you need it, how do we make sure that we are happy with the quality? Well, we first of all need to set the standards. And we can set standards, which we do through the Office of Health Standards Compliance, through compliance on a range of measurables. Then we can say, but if I'm going to pay you, you need to follow the standard treatment guidelines, you need to work within the formulary. You can work outside of there, but I'm not going to pay you for something different because we know this works. There's evidence in the international literature and that we are constantly measuring. We need you to be tax compliant as a provider. We need you to be connected to the digital system so that the patient's records can move between providers. And we need you to sign a contract with us on what you are going to do for the money we're going to pay you. And that's called accreditation. Then we need to go and measure that you are living up to the expectations of your accreditation. Now, to move somebody who's already there to where we want them to be is a piece of cake. But to move somebody who's far from there to where we want them to be, we have to make sure that there are quality improvement programs going all the time. That if you are not compliant or you are partly compliant, you must submit a performance plan. You must show us what you're going to do, how are you going to invest. And it doesn't matter whether it's a public hospital, a GP, or a private hospital, or a physiotherapist. If your environment and the conditions that we are agreed to together are not met, you agree on a plan of how you're going to get where you're going. And that will take time. But we've all got to focus on improving quality all the time.
You mentioned the cost of basically government as our custodian. Where's the money from the NHI going to come from?
Very nice question, because everybody says we don't have the money. So if you are paid a salary and you have a fixed salary, you can live a certain lifestyle with that salary. You can either blow it all on today's living, or you can put some into the future, some for today. You might have the next generation coming behind you. So you set the scope of what you're going to do with that money. And it's the same with a country. So we have a GDP, gross domestic product, all the money that this country earns, we know how much it is, whether we are spending it in the public sector through tax spending or whether we are spending it in the private sector. That's how much money we have as a nation to spend, the GDP. And we hope the GDP can grow so that there's more money for all of us, that we can uplift the well-being of people in society. But at any given point of time, that's how much we have. So right now, we spend 8.5% of that GDP on healthcare. Doesn't matter whose metrics you look at, they're in that ballpark of about 8.5%. The problem is what we spend it on. Now, to put it in context, the global commitment for spending on healthcare as a proportion of GDP is 5%. That's what we have agreed around the world as a reasonable point at which a country should be able to look after its people. So we're already sitting at 8.5%. OECD countries are sitting, those are the rich countries in the world, most of them, are sitting at around an average of 9%. The global average is 11%, but it's pulled by the United States, which spends more than 20% of their GDP on healthcare. Over 40% of the world's spending by one nation on healthcare. So if we look at countries who have similar GDPs and GDPs per capita to ours, and we look in that band, they on average spend about 6.5% of GDP on healthcare. So what are we doing differently that we spend so much healthcare, so much money on healthcare, and we don't get the kind of outcomes we would like to get, and we don't get the kind of quality we would like to get? And the answer is in our inequity. So we have a very inequitable society, both in terms of wealth, who owns what, and in terms of income, who earns what. And it's measured globally through what we call the Gini coefficient. There are other measures as well, but we measure the Gini coefficient. And ours is the worst in the world not something to be proud of. So we have this hugely inequitable society with a lot of poor people, a few very rich people, and the rich people own the resources and they earn the income. And the question is, how do we take the money that all of us spend to get the greatest impact for all of us in the country? And right now we're spending more than half of what we spend on 15% of the population, and the other half is spent on the remaining 85% of the population. You can fight about whether it's 16% or 17% or whatever, because people move between the sectors. It doesn't matter. The inequity is massive. Fighting about numbers is irrelevant when the differences are so huge. So the total inequity in healthcare is horrendous. We spend 15% of government spending on healthcare. That's the target under the Abuja Declaration, which is a global declaration on government spending in healthcare. That we're already at our target.
That's the 5%.
That's 15%. So 5% of GDP is the global target for the country. 15% of government spending, of tax spending, is the target from the Abuja Declaration. We already overmeet both of these. So we have to say we don't need to spend more money on healthcare. We must not spend more money on healthcare. We've got to spend what we've got differently. So in the public sector, we have to look at where are we wasting. What are we duplicating because we do it 9 times, one for each province? What are we wasting on corruption and fraud and things that get stolen in the public sector, including time that our practitioners steal from us? What are we doing to make sure that we don't send patients unnecessarily backwards and forwards and duplicate the care that they're getting because we don't have proper referral pathways and so on? So the public sector's got a whole lot of introspection to do to say we can do things better and we can do more with the money that we've got. The private sector is even more dramatic. So the private sector is spending 9% of everything on administering those 71 medical schemes before they spend 1 cent on the healthcare of the people who are the members and beneficiaries of their schemes.
So that's just the different products.
Just paying for pre-authorizations. Yes, you qualify. No, you don't. Paying the trustees of the funds, paying the principal officers and their administrations, paying the administrator, the actuaries. Before 1 cent is spent on healthcare, 21 billion has already been spent. So you've got to ask ourselves, is this efficient? And there are many papers from around the world that says if you get rid of so many different schemes, so many different ways of paying, you already got administrative efficiencies. Then that needs to be mirrored in the practice. So if I'm running a practice or a hospital, I can get patients who are going to get paid for by any one of those 71 medical schemes. So my practice administration needs to be able to cope with that. That costs me. We have designed ways in which we keep people apart and not working in multidisciplinary teams. We need to remove those impediments to people working together so that it's easier for them to work together and reduce cost. We've got to make sure that I don't get a new file opened every time I go from the dentist to the GP, then I move in another GP in another hospital in another place. Now I've got all these files all over the place, more x-rays, more lab tests, more this, more that. There's lots of waste in the system caused by duplication. And then there's over-servicing. We have a system where we pay fee for service. So you pay for every widget. You as a patient don't know whether that item was ever even on your script. You don't even know whether the doctor was authorized, was allowed to charge you on any of these many, many codes. So you can't, you as a user of the system can't control whether you're paying more or less. And if you are in a comprehensive scheme where the scheme is paying everything, you don't even question it. If you are paying in, you say, well, I didn't get this, you might question some things. But you're not in a position of strength especially if you're the one who's just come out of hospital, to challenge the practitioner and provider. And so we have a lot of over-servicing that goes on. I've already alluded to the GP's work being done by specialists. That's wasteful because we pay a specialist more because they got more training and so on. So just as the public sector, and then by the way, the private sector is not without their fraud and corruption. Last year they had a conference where they presented a paper that 28 billion rand is defrauded from the medical schemes and the providers per year. 28 billion. That's
just in the private sector.
Yeah, that's 6 times more than the corruption reported in the public sector in the same period. Let me say that again. 6 times more than was reported in the public sector. And I'm not saying the public sector reported everything. I'm just saying we have a corrupt, wasteful society. So the focus has to shift from where we're going to get more money from to how do we use what we got more efficiently. So Section 49 of the National Health Insurance Act says every year when the budget is put together, the fund is entitled to an appropriation. So at the moment, the appropriation goes to the provinces and the national departments. The provinces put money into the health departments, and the national department gets money which it sends to the provinces to spend. The section in Section 49 says that money needs to shift. And it needs to shift out of its current allocations through the provincial equitable shares and the grants that go to provinces, and it needs to come into the fund, and the fund must purchase the healthcare. It also says that the Minister of Finance may introduce a new money bill, which is in terms of Section 77 of the Constitution, where the Minister of Finance will then be empowered to introduce payroll tax and levies and other things. If necessary, he's empowered to do that.
Oh, so there's a tool to do it, but
there will be a tool to do it. It may not be necessary because we may save so much money that we don't need those tools. There's also, I think we will need some of those tools, but they can debate that down the line. There's also a provision that the tax credits, which are currently a subsidy that the state doesn't pay to, but allows you to deduct from your tax.
They basically refund you.
They basically refunding you to have a medical aid. Now, if you're not having a medical aid anymore because the fund is paying for all your healthcare, then you don't need the tax credit. That money should accrue to the health system. So all those shifts and changes can't happen in a short space of time. They certainly can't all happen at the same time, and they will need to be phased in as the changing purchasing and provider arrangements change.
What's the time frame that we're looking at?
So the Act has got 2 statutory time frames, which are built into the transitional provisions, which are, for those who are interested in Section 57. So the first phase is that it started last year with the legislative reforms, and it runs to 2026. And if you read the contents of phase 1, they're essentially creating the capacity to run the fund. Remember, today we don't have a fund.
Yeah.
We don't have a board. We don't have an administration. We don't have money in a fund. There's nothing. There's a little branch under me in the national department who is busy doing the planning for all of this. So the next 3 years is to create that capacity. Get the board, get the governance in place, get the administration in place, and begin testing the mechanisms of the changes in the way we're going to pay for healthcare. And the second phase then starts from late 2026 or the second half of 2026 to 2028. And that's where there should be real money in the fund to start buying. Realistically, that should get us the foundation of the reforms, but reforms of this magnitude can go for a very long time. And we see countries that 20, 30, 40 years later are still changing things and reforming because the environment changes, because the economy changes, healthcare changes, and so on. It's an evolving process.
Talking about changing and evolving process, we are currently seeing change in our political system, the GNU. How is that going to impact NHI and the implementation of it?
So during the lead up to where we are now, where an act was assented to by the president on the 15th of May this year, there have been political parties that have been opposed to the NHI. In fact, the majority are opposed to the NHI. They say in its current form. We support the NHI, but not in its current form. But then when you press for which current form don't you want, then what they're not telling the public is they want to maintain the status quo. And so you can't have everything the same as it is now. And if you want to not go to where the Act says we are going to, you need to engage on which pieces of where we are going you don't like. So there are those that are fundamentally opposed on an ideological basis. We want social health insurance, which has private people who earn money, paying for their own, running a parallel system from the government. The state long ago, in 2009, decided not to go that route. And that's what the green paper said, it's what the white paper says. So that train has left. We're on a different train now, and there's global precedent on the route that we are going on, that we've been following from Thailand, from Malaysia, from South Korea, from wherever. They're all slightly different, but that's the train we're on at the moment. There are those that believe that the NHI is designed to impoverish the poor and to pay bucket loads of money to private providers. Well, that's not how it's designed. Just by not nationalizing private hospitals and nationalizing private GPs does not mean you're going to pay them bucket loads of money and make them rich. On the contrary, they will get paid the same amounts of money for the same amounts of healthcare to the same people. That's how. There's no provision in the NHI Act that says I'm going to pay private people more than public people. So that's not an argument that we really understand or need to worry too much about. So then there's the essential argument is around protecting private income and private privilege. So there are those that believe that healthcare is an industry that generates huge amounts of money for the country. People pay VAT, they pay tax, company tax, and whatever, and it's good for the country. Well, if you regard health as a normal good like buying chairs and tables, well, I suppose you could argue like that. But if you believe that health is a public good, that you can't dictate what healthcare you're going to need when, and you are at the mercy of the world around you and
life.
Yeah, and being run over in the traffic and life, then the state has an obligation to put systems in place that make sure that when you need it, you get healthcare. And that's what Section 27 of the Constitution says. So there are these balances. So the government of national unity is something new to all of us. We will have to watch and see. Ministers will have to lead their portfolios. We have an act. Unless they decide in the government of national unity to take it back to Parliament and review all or part of it, that's the direction that we're going. And we'll be guided as we go forward.
We've spent the bulk of the interview going into understanding it, the pros, etc. What would you say is your biggest concern around the NHI in its current form?
So my concern is that people will do everything they can to sabotage it, and people with privilege will always try and protect their privilege. So my biggest sadness, if you like, is the amount of greed and selfishness that we have generally in society. And it plays out in corruption and fraud and the me syndrome, where I look after myself and everybody else must deal for themselves. So my hope, rather than my biggest concern, would be that people find a way to sit around the table, come and talk to us. There will always be different views on anything. And that's fine. That's what keeps us sharp. It's what keeps us thinking. But if we don't actually implement, if we drag and just keep going round and round the same block of researching and allowing the entrenchment of the current bad practices that we have, all of them, and we defer and delay regulation of things because we're waiting for a change, the inertia is our biggest enemy. Rather change, be decisive, do something. And if it doesn't work, well, then you didn't do all your homework and maybe you should have done it a different way. But that's what people told me in 1994 about the new South Africa, you know. It can never happen. People are going to leave the country and there'll never be enough money. And we've messed up some things and we've done some things well. And what we have to do, and your generation after mine, must fix the things that need to be fixed. And you've got to get involved. You can't shout. I keep saying to colleagues around me, get in the bull ring, fight, make change. Don't sit on the edges and shout and make noise, or sit on the fence and decide I'll go this way if and I'll go that way if. So I guess my plea is that we find ways to consult. We find ways to sit around the table. We find ways to find the common ground and build on the common ground. And things will change around us, you know. No piece of legislation is static.
Thank you. Thank you for making time and making all of this possible.
Appreciate it.
Guys, hope that's been insightful. Please let us know what you'd like to hear, when, from who. But before that, don't forget to like, subscribe, share. same place, same time. Palatable Politics.